Thermo Fisher Scientific presents The Next Step, a diagnostic testing series. Created to help physicians appreciate the nuances of laboratory testing, Thermo Fisher Scientific has developed a series of short videos in the Next Step series by noted experts, focusing on demystifying laboratory testing in common, but sometimes difficult to diagnose autoimmune diseases, such as rheumatoid arthritis, systemic lupus erythematosus, and celiac disease. In this series, we will address 4 key questions when it comes to laboratory testing. These include: who should be tested? When should these tests be utilized, and in what order? Which tests are appropriate for a diagnostic workup? And finally, and most importantly, what should one do with the results? Your host will be Dr. Anagh Vora, the U.S. Medical Director Autoimmunity at Thermo Fisher Scientific. Dr. Vora, in his current role, directs institutional and physician education. He has lectured extensively at medical schools in the U.S. and Europe, including Harvard, Stanford, and the Karolinska Institute, on the application and appropriate utilization of laboratory testing.
I'm Anagh Vora, and as a laboratory physician and clinical pathologist, I understand the difficulty that many of us face in navigating the complexity of laboratory testing, especially with newer technologies such as next-generation sequencing or the latest clinical biomarkers. But if not ordered in the right sequence or used in the correct clinical scenario, even older tests can be confusing. Numerous paradigms exist in diagnostic testing, but 3 key concepts should be considered when utilizing laboratory tests. First, for most diseases such as rheumatoid arthritis or celiac disease, a single laboratory test is not diagnostic. Instead, the diagnosis is made by a combination of clinical signs and symptoms, with laboratory testing confirming the clinical symptomology. Second, no test is perfect, that is 100% sensitive and 100% specific, and all tests will either falsely label patients as positive when they don't have disease and miss patients when they do. The goal is to minimize this problem by testing the correct population, testing only those who are at risk for disease, thereby increasing pretest probability and improving the effectiveness of testing. Third, it is essential to be familiar with the platform and methodology utilized on the test ordered. The corresponding results are not always comparable since the performance varies between manufacturers. When in doubt, it's always a good habit to ask the clinical pathologist at your institution for guidance. He or she will be able to walk you through the advantages and disadvantages of different laboratory testing paradigms.
In this video, we will be discussing the essentials of laboratory testing in the diagnostic evaluation of celiac disease. Dr. Leffler is Associate Professor of Medicine at Harvard Medical School and currently serves as the Director of Research at the Celiac Center at Beth Israel Deaconess Medical Center. He currently divides his time between patient care, quality improvement, and translational research. He sits on numerous national and international committees, including the Oslo Group, developing consensus statements for celiac disease and related digestive disorders.
Hi, I'm Dan Leffler. Celiac disease is an immune-mediated disease characterized by loss of immune tolerance to dietary gluten in genetically susceptible individuals, resulting in small intestinal mucosal damage and other systemic manifestations. Celiac disease should be distinguished from both gluten sensitivity or intolerance and/or irritable bowel syndrome, which may have similar or overlapping clinical features but do not result in intestinal damage.
Celiac disease affects approximately 1% of the world's population and is seen most commonly in the US from patients of European ancestry, but can be seen in patients of diverse ethnic backgrounds, including African Americans and patients from India.
Who should be tested?
Testing for celiac disease should be considered in 3 different patient populations. Those with classical GI symptoms, including diarrhea, malabsorption, weight loss, and abdominal distension or pain. Patients without overt GI symptoms, with unexplained iron deficiency anemia, elevated liver transaminases, short stature, delayed puberty, skin rashes, dental enamel defects, and persistent aphthous stomatitis are all possible manifestations of celiac disease and should be tested. Patients with Down syndrome or pre-existing autoimmune diseases, including type 1 diabetes or autoimmune thyroiditis, are at high risk for celiac disease compared to the general population, greater than 5%, and should be tested.
When should testing be performed?
Testing for celiac disease should not be delayed if patients fit the criteria for the appropriate testing population, and can be initiated by the primary care provider, especially since many patients typically underreport symptoms or may not have classical symptoms. This is particularly important since 80% of patients in the US with celiac disease are not correctly diagnosed. Even when the correct diagnosis is established, the average duration of symptoms prior to that diagnosis has been approximately 11 years. Finally, when testing for celiac disease, it is important to ensure that the patient is currently consuming gluten, as eliminating gluten may normalize serologies and biopsies. We will discuss other diagnostic options for patients that are on a self-imposed gluten-free diet in a later section.
Which tests are appropriate for a diagnostic workup in celiac disease?
The diagnosis of celiac disease is established by a combination of clinical signs and symptoms, including direct and visual inspection of the duodenum via endoscopy,
as well as serological testing and genetic testing in appropriate cases, and microscopic assessment for mucosal damage of endoscopic biopsies. In this video, we'll discuss the next steps in the laboratory testing of celiac disease.
Laboratory tests for celiac disease.
Multiple authorities, including the US, British, European, and pediatric guidelines, recommend a combination of the following diagnostic tests, usually ordered concurrently or in a tiered fashion.
Please keep in mind that serology for celiac disease should be thought of as screening tests in order to help triage patients who can safely be followed and those who require further testing, including intestinal biopsies. Let's look at these serological tests in more detail.
Tests for celiac disease include tissue transglutaminase IgA and IgG.
Tissue transglutaminase, or TTG, is a family of enzymes involved in protein cross-linking, preventing protein hydrolysis or degradation. However, in susceptible individuals, dietary gluten interacts with TTG, resulting in the production of anti-transglutaminase antibodies, including both IgA and IgG, through immunomodulation of B cells and direct T cell mediated damage to the intestinal mucosa. In the vast majority of cases, IgA antibodies against TTG is the single most useful biomarker for the diagnosis of celiac disease and has a sensitivity and specificity greater than 95 to 98%. However, an important, though often overlooked point for many physicians is recognizing that even small changes in test performance between different laboratory assays will have significant clinical consequences. For example, a relatively minor 3% decrease in specificity, 98 versus 95%, can lead to almost a threefold increase in unnecessary intestinal biopsies due to increased false positives. It is vital to understand the importance of both sensitivity and specificity when assessing a diagnostic test, rather than relying on either parameter in isolation. Increased accuracy with less false positives and negatives is only achieved by selecting the test with the best combination of sensitivity and specificity, thereby improving overall clinical outcomes.
Additional tests include endomysial antibodies, complete blood count, liver function tests, EMA.
Endomysial antibodies, or EMA, target the endomysium, or the connective tissue surrounding smooth muscle cells, historically tested in monkey esophagus and now more commonly in fetal umbilical tissue. The sensitivity of EMA in expert hands is similar to TTG. However, we do not recommend it as a first-line option since its use is operator-dependent, both for performance as well as interpretation. Additionally, the target antigen in EMA is identical to that of tissue transglutaminase test. Despite these limitations, EMA can still be useful given the right clinical circumstances.
CBC and LFT.
Other tests may show iron deficiency anemia or persistent elevation in serum aminotransferases, which may also help in ascertaining the correct etiology.
Tests not recommended include
Stool and salivary tests, along with over-the-counter tests for celiac disease, do not meet minimum requirements for diagnostic accuracy or precision. These tests show unreliable performance in clinical practice and therefore should not be utilized. Native anti-gliadin tests have a much lower accuracy than TTG and should also not be recommended.
special clinical situations that require second-tier testing.
We've covered diagnostic testing for the majority of cases with potential celiac disease, but there are clinical situations which can be challenging for many physicians and require further guidance. Dan, for instance, what is your recommendation for testing patients that are already on a gluten-free diet or pediatric patients younger than 2 years of age?
These are important factors to consider, especially since many patients are increasingly already on a gluten-free diet prior to testing. However, second-tier testing may aid in the correct diagnosis of these individuals, as well as younger patients or even patients with IgA deficiency. Let me explain further.
Testing in symptomatic individuals on a gluten-free diet.
The sensitivity for celiac disease detection is decreased in individuals who are not currently consuming dietary gluten. Symptomatic patients who do not wish or cannot tolerate eating gluten prior to testing should still be tested in the normal fashion for TTG-IgA, with the understanding that if the test is negative, celiac disease has not been ruled out. Secondary genetic testing may be performed to determine if the appropriate at-risk haplotypes, HLA-DQ2 and DQ8, are present in these patients. Though HLA testing is more expensive than serology, if negative, celiac disease is essentially ruled out for life and does not have to be repeated. However, if it is positive, then celiac disease is still under consideration, and a gluten challenge followed by endoscopy with biopsy should be considered.
Testing in patients less than 2 years of age.
Antibodies against deaminated gliadin peptides, or DGP, both for IgA and IgG, are recombinant synthetic gliadin peptides that mimic the modified gliadin sequence in TTG. DGP has been shown to be more diagnostically sensitive in patients less than 2 years of age compared with TTG, and should be ordered in parallel with TTG and total IgA in this population in order to increase diagnostic accuracy. Anagh, what about when there's discrepancy between clinical features versus serological testing, or between the serology and the biopsy results?
Possible causes for positive clinical features but negative serology include
There are several possibilities here. For example, the patient may not actually have celiac disease, and an alternative diagnosis should be considered, such as gluten sensitivity or food allergy. The patient may have IgA deficiency, and this possibility should be explored if not tested for previously. The patient may already be on a gluten-free diet, leading to a false negative serology. Dietary guidance on appropriate gluten ingestion may be necessary prior to retesting. Genetic testing may also be utilized, as described previously. Finally, it's important to remember a small percentage of celiac patients are seronegative at time of diagnosis. In this situation, repeat testing is recommended after 3 to 6 months.
possible causes for positive serology and negative small bowel biopsy include
Early stage disease with normal or near normal biopsy may only consist of mild increase in intraepithelial lymphocytes, or may represent other causes of microscopic enteritis. Review of the biopsy by a pathologist familiar with the diagnosis of celiac disease may help resolve serology biopsy discrepancies. Genetic testing may also be valuable in this situation to help determine the likelihood of celiac disease.
Let's recap some of the important tests for the workup of celiac disease. Total IgA, tissue transglutaminase IgA and IgG. Additional tests to consider: endomysial antibodies, complete blood count, liver function tests, genetic testing for HLA subtypes DQ2 and DQ8, tests not recommended, stool and salivary tests, over-the-counter celiac tests. What should one do with the results?
It's vital to understand The role of serology in this clinical situation is to assist in confirming the clinical diagnosis. No single test should be used in isolation to make a diagnosis or treatment plan. However, if the diagnosis of celiac disease can be made confidently, there should be no delay in referring the patient appropriately or prescribing a gluten-free diet, as avoidance of dietary gluten allows for mucosal healing and normalization of serology in most individuals.
Additionally, since maintenance of a gluten-free diet is very challenging for most patients, newer therapies are now in late-phase studies for the treatment of celiac disease. In the future, these therapies are predicted to play a greater role in the management of patients with celiac disease.
Thank you for watching The Next Step, a diagnostic testing series. For more information or to watch additional videos, please visit our website at thermoscientific.com/Fadia.